On this podcast, we go one step beyond publications and guidelines to speak directly with leading experts in interventional pulmonology. This podcast will address not only fundamental topics in exciting publications, but also unconventional topics for which the evidence base isn't that robust. The views expressed on this podcast are those of the speaker and not necessarily endorsed by the AABIP. This is your host, Udit Chadda, an assistant professor at the Icahn School of Medicine at Mount Sinai. And with that, let's dive into the next episode. Like any new tool in our kit, the transbronchial forceps is also generating a lot of excitement. Today, I plan to discuss with Dr. Christopher Radchenko as to whether the forceps has lived up to its hype. I'm talking about the transbronchial forceps for EBUS, so intranodal forceps biopsy or mini forceps biopsy. Dr. Radchenko is an assistant professor of medicine at the University of Cincinnati. He's an interventional pulmonologist who completed his training at VCU. Thank you for joining me on the podcast today.
Thank you. It's a pleasure being here. Thank you for this opportunity.
And do you have any relevant CO conflicts of interest to disclose?
I do not have any conflicts of interest.
Perfect. Let's dive in. So I have come across about 6 or 7 studies now reviewing anything between 50 to 80 patients, dating as far back as 2008 by Felix Hurt, using forceps as big as 1.9 millimeters. One study using electrocautery probe to create a hole in the airway wall. And, a few of the studies have shown a better diagnostic yield than regular EBUS TBNA with the 22 gauge needle. And a few have said that mini forceps biopsy does not add any value or improve diagnostic yield. So, Chris, in your practice, what is the indication for using a mini forceps biopsy?
Perfect. Okay. So if I could take a moment here, I just wanted to shape the discussion leading into mini forceps biopsies and how we're using it currently. So if I could start, I just wanted to say that over the years, so we've seen EBUS truly become the primary modality for sampling tissue that's accessible by bronchoscopy. And this was seen or shown previously in chest guidelines on mediastinal staging. But just as with many technologies in the field of medicine, we're always striving to improve the procedure, improve the technique, and that's certainly no different when we're discussing aspects of EBUS. So, so we've seen advances in the EBUS scopes. I'm sure we're going to continue to see that. We understand what may be achievable with the EBUS scope, accessing potentially targets across vascular territory. Oftentimes, we'll introduce the EBUS scope through the esophagus to sample other stations. But in step with these advances, we've seen improvements in the instruments through which biopsies are being obtained. And that's where we're seeing needles sizing from 19 gauge through 25 gauge, different proprietary designs for which there are a few, and as well as the realm of what we're talking about here today with EBUS guided forceps tissue acquisition. So to summarize briefly the data on EBUS and mini forceps biopsy, let me first touch on a few studies. So first, looking at the ACCP guidelines, third edition, Silvestri and colleagues, when they were summarizing EBUS TBNA for non-small cell carcinoma, they were showing sensitivities around 90%, specificity 100%, positive predictive value 100%, negative predictive value of 86%. So very comparable with mediastinoscopy. And through time, we've seen these hold true. With EBUS TBNA usually being the first invasive test employed for tissue acquisition in the setting. However, when we're looking at benign lymphadenopathy or isolated mediastinal lymphadenopathy, possible reactive lymphadenitis, this scenario with EBUS is that it performs well, or at least the results need to be interpreted much more critically. So the first study that I really like, I wanted to touch on was the REMEDY trial. So Neil Navani, they published a great trial, published in the Blue Journal 2012, a prospective multi-center trial studying healthcare costs of EBUS compared to mediastinoscopy in patients with isolated mediastinal lymphadenopathy. So they had looked at 77 patients, all underwent EBUS TBNA. Those without diagnoses underwent multidisciplinary review, followed by mediastinoscopy, and then followed beyond 6 months. And what they found was that EBUS prevented 87% of mediastinoscopies, but it failed to provide a diagnosis in 10 patients or 13% of patients, all of whom underwent mediastinoscopy. So what they found was that the sensitivity was good for isolated mediastinal lymphadenopathy at 92%, But here the concern was that the negative predictive values of EBUS TBNA in isolated mediastinal lymphadenopathy was 40%. So really not as high as what we're seeing with malignant disease. Then we had a couple of studies after that. Matthew Evison and colleagues, they performed a study on 100 patients with isolated mediastinal lymphadenopathy. They all underwent EBUS TBNA. The study was conducted with a higher proportion of reactive lymphadenopathy to assess diagnostic performance. And what they found was that 52% of patients were diagnosed as pathologic, while the remaining 48% were diagnosed as having reactive lymphadenopathy. And so I think here, how to characterize those 48 patients and characterize them as true negatives was if all pathologic sampling and a minimum of 6 months of follow-up failed to yield an alternative diagnosis, or that the referring physician did not consider the patient as having an alternative diagnosis. So that criteria, I guess you could debate that a little bit, but with this criteria for true negative, they found that the diagnostic accuracy was actually a little bit higher. They were saying 91% was the diagnostic accuracy, with a negative predictive value as high as 84.2%.
And that 6 months is sort of empiric, right?
It is, yeah. So on that trial, they looked at 6 months, and that's kind of what they used to follow up. And I think that could be a point that you debate. And then another study that I liked for this point was Valu and colleagues in 2017. But they reported their retrospective single center study in the UK. They performed EBUS TBNA on a predefined patient cohort of isolated mediastinal lymphadenopathy. They combined pathologic and clinical features to determine the final diagnosis. They had 126 patients for which they found clear pathologic diagnoses in only 43% of patients. They had benign or reactive lymphoid cells, not confirming a pathologic diagnosis in 43% as well, while nodal sampling was insufficient in 8% of patients. Mm-hmm. So really in this patient cohort, EBUS did not yield a clear pathologic diagnosis in 57% of cases. So with reactive lymphadenopathy, these patients underwent a combination of further investigations. They had radiographic follow-up with CT chest or PET scans. And with this, they report the final sensitivity of about 80%. But again, I think that with 57% of these isolated mediastinal lymphadenopathy cases not having a clear pathologic diagnosis, then I think that how they handle the true negatives in this study is something that I think we would look at very closely. So with that, then this topic then starts coming in with regards to EBUS guided forceps biopsy or mini forceps biopsies. And we have a couple of studies. And as you had mentioned, so there was 6 to 7 studies we're looking at. Again, some of them have obviously limitations, but I think that the biggest ones to look at and to consider when we're framing this discussion is a few. And let me just touch on a few of those if I can right now. So Alex Chen and Eric Christian in 2011, they conducted a study using EBUS TBNA and mini forceps biopsy. It was a prospective single center study with 50 patients, 74 lymph node stations with a low pretest probability of malignancy. And here they found that the yield of EBUS TBNA was 81% versus 91% for EBUS mini forceps biopsy, which although was not statistically significant, what they were finding is that if you combine these modalities, there was statistical significance, yielding 97% when used together. They didn't have any complications, and they didn't note that there was an increase in the length of procedure. Following that, Carl Joseph Frank and colleagues in 2012 performed a single center prospective trial on 50 patients, all with unexplained lymphadenopathy. They underwent EBUS TBNA as well as EBUS forceps biopsies. And what they found was there was an 82% diagnostic rate utilizing both combined modalities, with EBUS forceps having 72% diagnostic yield. But look at this, they only had a 50% diagnostic yield with EBUS TBNA. They found that EBUS TBNA tended to do better with malignancy. And for complications, they had bleeding in 3 cases requiring installation of topical vasoactive agents, moderate grade pneumomediastinum in 1 patient there. And then the other thing I think that's interesting is that the next study I was looking at was Darwish and colleagues, published in Respiration 2013, single center trial, 48 patients, all underwent EBUS TBNA followed by EBUS transbronchial forceps biopsy. The negative results were followed by mediastinoscopy, open thoracotomy, or CT imaging. They found an overall diagnostic yield for malignancy was 71% for TBNA, 83% for transbronchial forceps biopsy, and combined it was 88%, which wasn't statistically significant. But here for benign disease, the yield of EBUS TBNA was 64% compared to 89% for EBUS transbronchial forceps biopsy, with a combined yield of 93%, which was statistically significant. So of note, for sarcoidosis, their yield of EBUS TBNA was 61% compared to EBUS transbronchial forceps biopsy at 89%. The combined yield being 94%, which was statistically significant. So here, I think that we're starting to see a pattern that perhaps in malignant disease that EBUS transbronchial needle aspiration may outperform the forceps. However, in benign disease, and certainly combining both modalities, we can increase the diagnostic yield. One of the things I will say that is a novel approach, which I do want to mention because this is a very novel study, and it was one I think that you were referring to as well. With Kyle Bramley and colleagues in 2016, they conducted a study where they employed a cautery-assisted transbronchial forceps biopsy in 50 patients. It was prospective single center under EBUS guidance. So of 111 total node sample, they found that EBUS TBNA was successfully diagnosed 85% of nodes, while the cautery forceps diagnosed 80%. That wasn't statistically significant. But for malignant disease, EBUS TBNA diagnosed 100% of the time compared to 78% of the time for the forceps. So again, here we're seeing that for malignant disease, the transbronchial needle aspiration outperforming the forceps. But for granulomatous inflammation, the cautery-assisted EBUS transbronchial forceps biopsy diagnosed granulomatous inflammation in 90% of the lymph nodes compared to only 33% for EBUS TBNA, which was statistically significant. They didn't have any cases of mediastinitis. They had 2 cases of pneumomediastinum without clinical symptoms, they report, and 1 patient with temporary bleeding that required saline and epinephrine application. And then the final thing, and the final study that I want to mention, I do want to mention, we had published a study last year on respiratory medicine. I was with one of my mentors, Tim Setley, at University of Missouri in Kansas City. So we conducted a retrospective review of our cases where we used EBUS mini forceps biopsy. So we included 82 patients for a total of 84 target lesions. These patients underwent EBUS TBNA with we used a 22 gauge needle followed by EBUS mini forceps biopsy. ROSE was used for all cases. But when we were defining the pathologic findings as diagnostic or not, I feel that we were a little bit more stringent. So the sampling to be definitive for granulomatous lymphadenitis had to truly demonstrate clearly defined granulomatous inflammation. And we didn't give credit for epithelioid histiocytes, multinucleated giant cells, asteroid bodies, Schaumann bodies, and so on. So, and finally, and furthermore, our non-definitive results, which would include benign lymphoid elements, tissue, or lymphoid tissue, needed to be followed very precisely. So these patients either had second site biopsies, alternative sampling to acquire a diagnosis, mediastinoscopy, and if they didn't, they were followed for we followed these patients for at least 12 months. Again, kind of looking back at maybe 6 months may not be long enough duration to kind of follow these patients. So what we found was that for diagnostic yield, EBUS TBNA was 75% compared to mini forceps of 81%, which was not statistically significant, but the combined yield was 94%. So using both of those modalities, there was a significant increase for combined yield. But interestingly, when we stratified into malignant versus benign disease, we did find statistical significance. So for malignant disease, we found that EBUS TBNA had a diagnostic yield of 100% compared to EBUS forceps or mini forceps biopsy at 81%. And conversely, for non-malignant disease, EBUS TBNA had a diagnostic yield of 54% versus 80% for the mini forceps biopsy. We also saw that in granulomatous disease, there was significant difference favoring the mini forceps biopsy. So that's my summary of EBUS in benign disease and how we kind of got to this point with mini forceps biopsies. So now let me get back to your question there, and sorry if I was going on rambling there, but
No, that was very, very detailed. I was making notes as you spoke.
Perfect. So here's what we do in our practice. So when we evaluate a patient who requires tissue acquisition, the entire case has to be planned appropriately. So just as you would conduct an anesthesia pre-assessment, we evaluate the patient, we consider the differential diagnosis, consider the pretest probability of disease, whether it is someone or some of the more challenging diagnoses to acquire, such as like sarcoidosis, lymphoma, granulomatous lymphadenitis, or even if you have a malignant appearing disease where you have necrosis. Those can be oftentimes challenges when you're trying to sample these patients with EBUS. So for cases that we're suspecting benign lymphadenitis, we want to conduct a single procedure with the highest likelihood of acquiring a true diagnosis. And in these settings, we may adjust our approach with real-time data acquired through rapid on-site evaluation.
Mm-hmm.
So, for example, this may be where we reach to an instrument such as a mini forceps in that setting. So, for benign lymphadenitis, and again, adjusting our technique based off of the information we're getting from a rapid on-site evaluation. The next setting that we would use this in is for lymphadenopathy, where we're considering a lymphoproliferative disorder,
Mm-hmm.
where lymphoma has a higher pretest probability. This is a condition where if we were attempting to diagnose through EBUS, we would really reach for all instruments available to secure that diagnosis. And this is, again, where I would use a mini forceps. And then finally, for bronchogenic carcinoma or metastatic disease, we're seeing in the field the ever-changing realm of molecular analysis, next-generation sequencing, PD-L1 expression analyses, and these are scenarios where obtaining a confident diagnosis on cell block or immunohistochemical staining is only part of the procedure. We've all had those situations where we make a diagnosis of a carcinoma without further classification, or it is a defined non-small cell carcinoma, only to be asked by the oncologists, when they see them a couple of weeks later, that we need more tissue. So if I'm doing one of those cases and we are being asked to obtain more tissue for these particular analyses, and so for an EBUS where the cellularity, I'm getting sampling and the cytotech is looking at it and saying, the sampling, the cellularity might be sparse or we need much more tissue, then this may be a setting where I'll also reach for a mini forceps biopsy.
Okay, perfect. Yes, I would just like to add a couple of things that, dissecting through the literature, I think one of the most important things that I consider is we want to look at the combined yield, because we're not going to go straight to the mini forceps, right? So
Correct.
you do an EBUS TBNA, you create a hole, you create a tract, and then you introduce the forceps. So the additive yield of the mini forceps is something that I'm looking for. And most studies have shown an additive yield, but one of the criticism I do have of many of these studies is that the TBNA yield is on the lower end of reported literature yield. So it's not as good as the better studies or the bigger studies have shown with EBUS TBNA. So maybe there's that's one of the reasons why we get significant statistical improvement
Correct.
if
Yeah,
you look at studies. Anyway,
absolutely.
Anyway, thanks for being so detailed with that. I'm gonna have to listen to this all over again to recap all of this. But let me throw two scenarios at you, and one is related to lymphoma, where meta-analysis have showed a 66% sensitivity of EBUS, and sarcoidosis, where a recent meta-analysis showed an overall diagnostic yield of 79%. So, in, let's say, scenario number one, you have a lymphoma patient. What do? What gauge needle do you use? And then let's say if Rose is negative, do you go straight to your forceps or do you go to a larger gauge needle? And on the other hand, if Rose is positive, do you stop or do you still do a forceps biopsy to get more architecture?
Perfect. These a very great scenario to discuss. So,
Scenarios, yeah.
yes,
Sorry about
scenarios,
that.
absolutely. So, for patients where lymphoma is on the differential, certainly I feel that this is one of those scenarios where we have to be very exact with our sampling and we have to be as definitive as possible, just knowing the challenges that we have with EBUS sampling. So the challenge with EBUS TBNA for lymphoma is, as you mentioned, the diagnostic yield may be in the realm of 65%, somewhere in that realm. Although there aren't robust studies on best needles and techniques to use, looking at some of the previous studies, I think it's important for this scenario. So there was a couple, and I know that the realm of the 19 gauge needle has really been something that has been published on, although the studies don't have a large sample size in many of them. But a couple that I was looking at, just to kind of frame the way that I approach these cases, is that if you look at Van Holden, and Ash Sachdeva and colleagues. So last October, they published a study on comparing the cell blocks on a 19 gauge versus a 21 gauge needles. And they did find that the mean cell area of samples was larger, 7.3 millimeters versus 5.2 millimeters, which was statistically significant. And this area was seen in the malignant subgroup, but not the non-malignant subgroup. So that's one consideration. Porphyritis and colleagues published their findings on the 19 gauge versus 21 gauge needles in EBUS, TBNA, and ERJ in 2017. And they found that, again, the 19 gauge needles provided more histologic material compared to the 21 gauge. Their study compared 35 patients in the group and showed trends favoring the 19 gauge needles for diagnostic yield and accuracy with regards to cytology and histology assessments. And then there's a couple other studies as well, including yours, which was published in JOB 2018, which I think we'll summarize in the following section with sarcoidosis. But there are studies.
That's the main study. I want you to focus on that.
On that. Sure. Well, I was going to push that to the next scenario when we talk about sarcoidosis. But
maybe the next podcast.
Sure. But getting to back to the scenario regarding lymphoproliferative disorder. So my practice based off of this is to use a 19 gauge needle until we truly have more kind of definitive data.
So you start with the 19 gauge.
So I start with a 19 gauge needle. So I will access the targets with conventional EBUS methodology for TBNA sampling with or without suction, and have rows do their evaluations on the first samples. So meanwhile, I ensure that samples are sent for flow cytometry. Definitely make sure they're sent for flow cytometry and placed in the appropriate media for that. With regards to rapid onsite, so I do utilize them for assistance in target sampling and to steer me in the best direction for sample acquisition. However, I do not confidently rely on their smear cytology assessment for a definitive diagnosis. So it's always easier to obtain maximal tissue during a single procedure than having to repeat the procedure afterwards to say we needed more tissue. So therefore, after I have adequate sampling for cell block and discussing with our cytotechnologist, I will perform EBUS-guided mini forceps biopsy sampling, again, being guided by the cytotechnologist, the ultrasound appearance or configuration of the lymph node, as well as looking at the pre-procedure data that we have, if they have a CT scan or a PET scan. So we perform EBUS mini forceps biopsy after the TBNA with the 19 gauge needle. I generally obtain 6 to 10 samples for complementary analysis. And then one other thing is that we started sampling a different needle here at UC, the Acquire needle from Boston Scientific. It's a smaller gauge needle. It comes in a 22 gauge and 25 gauge, but it has a proprietary needle tip design. So there isn't enough data at this point to truly tell if this is the needle that is going to be more diagnostic, but it does look a little bit different. And when we're passing the guide wire through, it does look like it can potentially get more of a core sample.
Okay, so you're basically using the forceps irrespective of what row shows.
So, and let me tell you this last piece of this. The answer to that is yes. But here's the one thing to consider, because ultimately, this is the reality of the bronchoscopist. So interpreting the results post-procedure and devising a plan for next steps in diagnostics after biopsy is always a challenge. So in the procedures where I know lymphoproliferative disorder is being considered, I try to ask myself, if the sampling is non-diagnostic, could I have done something further to increase my likelihood of achieving a diagnosis? So I try to ensure that in these cases, the answer is always no. So what do I mean by that? So here's what I mean. So would I have had better sampling if I did this case under general anesthesia as opposed to moderate sedation? Would I have had a chance to make a diagnosis had I used a larger needle? Should I have taken more samples? Was there another instrument I could have used to make the diagnosis? And in the end, I hope that the answer for this procedure is that I did everything I could and wasn't able to acquire the diagnosis. And so for me, it makes so that the next step in deciding the diagnostic evaluation is more straightforward. So if I performed EBUS without challenges in the anesthesia aspect, I sampled the largest needle gauge that I have. I employed mini forceps biopsy. I obtained ample tissue for pathology assessment, and I still didn't get the diagnosis. And lymphoma is a leading consideration. Um, so when they ask me afterwards, would you repeat the EBUS or what do we do next? For so that patient, under that setting, I would send that patient for mediastinoscopy or excisional biopsy if the target is amenable. And there's no question as to, well, did we just not sample it a certain way? Could we
Hmm.
repeat the EBUS? In that setting, I can say, look, I know that this is going to be a hard diagnosis to acquire. I do everything I possibly can so that after the fact, when I'm interpreting the results, I know that there's nothing more from an EBUS perspective that could be employed to try to secure the diagnosis. And that patient should be sent then for mediastinoscopy.
Perfect. So similar scenario with sarcoidosis now.
Hmm.
So let's say you start with EBUS and you have no granulomas on rows.
Hmm.
You go straight away to the forceps. And does this have any implications on whether you perform an endobronchial or transbronchial biopsy?
Perfect. Another really good scenario. And again, this is, I think, one of the challenges for EBUS is with sarcoidosis. So let's discuss this further if we could. Um, so if you look at the published data on EBUS for sarcoidosis, this is kind of what you were mentioning. You'll find a range for diagnostic yield. Some of the studies are reporting above 90%, and some are in the 30% range. So one challenge that we can all recognize is the population heterogeneity, the procedural variability, the pathologic interpretation variability among patients in different geographic ranges. So here in Cincinnati, being in a histoplasmosis endemic region, we have this to consider as well. So, however, looking at patients we're trying to diagnose sarcoidosis on, there are those that are high pretest probability and those that are low pretest probability, but they've been sent to us for an evaluation given the consequences of a non-diagnosed sarcoid. And so, one example I want to give you. So, at Virginia Commonwealth, we were looking at patients from our cardiac sarcoidosis experts. So, where patients had potentially an infiltrative cardiomyopathy, where sarcoidosis was on the differential. So, many of these patients underwent cardiac PET, which could demonstrate at times low uptake on non-pathologically sized mediastinal lymph nodes. So, they recognize that given the challenges with voltage gated guided endomyocardial biopsy and the diagnostic sensitivity being in the realm of like 20-30%, that they would ask us to perform EBUS because they felt that it was a safer procedure and it might be able to acquire the diagnosis without having to biopsy the myocardium.
Hmm.
So I can tell you this data is yet to be published, but I can tell you that these patients did not have diagnostic yields in the 70 plus 80, 90% range. I can assure you that. And that data should be published hopefully in the coming year.
Hmm.
But furthermore, at University of Cincinnati, we collaborate with a very well-known sarcoidosis expert, Dr. Robert Boffman,
Hmm.
where patients are sent to him for evaluation of very complicated sarcoidosis. So there are scenarios where patients may only have neurologic abnormalities, where a consideration may be sarcoidosis, or again, non-pulmonary manifestations of possible sarcoidosis, where there are no easy ways to acquire the diagnosis. So these patients may only have slight pulmonary manifestations or abnormalities, but again, acquiring the diagnosis would be very impactful for these patients because the consequences of potentially progressive disease as well as exposing them to cytotoxic therapies unnecessarily wouldn't be ideal.
Hmm.
So this is where I'll go back and let's briefly mention your study there. You had published with your colleagues a study on EBUS TBNA 19 gauge versus 21 gauge needles in 2018 and JOBIP. So with the 19 gauge needles, it would be assumed that there would be larger specimens. That's what we're assuming. Possibility of core samples, preservation of architecture, and that may be helpful for sarcoidosis. However, as you'd shown in your pilot study, that sample adequacy was statistically higher in the 21 gauge group, 73% versus 49%, with
22
fewer
gauge, yeah. Mhm.
with the 22 gauge, with fewer samples being bloody in the 22 gauge group, with no difference in diagnostic yield. So, with that, um, that the other thing that I do want to mention for the listeners, and I think that this is very important, With sarcoidosis, remember that this is a diagnosis of exclusion. So always think in your mind that if you have non-necrotizing granulomatous inflammation, you will always be asking yourself after the fact about ruling out all the possibilities. So this will include all the list of infectious possibilities, which can be necrotizing and sometimes non-necrotizing, especially for infectious possibilities.
Mhm.
And for the listeners, that's generally our fungal organisms, mycobacterial organisms, as well as other organisms, unusual organisms such as toxoplasmosis, schistosoma, rickettsia,
Mhm.
etc. We have to rule out autoimmune processes, including giant cell arteritis, which I had one recently with that,
Mm.
Crohn's disease, EGPA, toxins such as beryllium and zirconium, drugs, and mainly we see this with the immune checkpoint inhibitors, antiretrovirals, interferon, and anti-TNF agents. And then you have a whole nother category of other unusual conditions. So here's what we do in our practice for when we're evaluating a patient for suspected sarcoidosis. So we evaluate the case, we get a sense of the lymph node involvement, the parenchyma involvement, and targets for possible biopsy. I discuss with the patients the different biopsy modalities, the risk benefits of sampling. The sites we're interested in, what we're talking about, are EBUS lymph node sampling, random mucosal biopsies, BAL with a comprehensive evaluation for infection,
Mhm.
cytology, potentially flow for CD4, CD8 ratios. Then sampling, then the question of sampling for transbronchial parenchyma, whether it be with transbronchial forceps or sometimes transbronchial cryobiopsies. And currently at UC, we do have a study that we're collaborating with Dr. Boffman on. We're enrolling currently for a prospective trial where we perform all of these. So we perform all of those biopsies, regardless of what we're seeing on rapid on-site evaluation. So after I have all of this information, and and the plan is accepted by the patient and all parties, I perform the EBUS lymph node assessment. And here I sample with either a 21 or a 22 gauge needle. So I don't sample with a 19 gauge needle. Again, just kind of looking at some of the data that we have thus far. So
Mhm.
21 or 22 gauge needle in standard EBUS fashion. So I'll send the first, now this is important, I send the first one, the first sample for culture. I don't want to contaminate the needle. So the first sample off of the needle I send for culture, knowing again that if this ends up showing non-necrotizing granulomatous inflammation, diagnosis of exclusion, I want to make sure that I don't have an infectious etiology that's causing this.
Mhm.
Then I'll send the next one for Rose assessment. So if it appears like a good lymphoid sample, then I will send the next one for flow cytometry. But I will tell you, at our institution, very rarely will our cytotechnologist call granulomatous inflammation. I proceed as though that it may not be present. And then what I do afterwards is then I complete my passes with EBUS TBNA. Then I move on to sampling with EBUS mini forceps biopsy at that suspect lymph node. Thereafter, I perform random mucosal biopsies. If you see a suspicious mucosal pachydermia, thickening, something like that, I'll target these areas. Otherwise, I target basically random mucosal biopsies in a random distribution, remembering to stay off the posterior membrane, generally 4 to 6 mucosal biopsies. I then perform BAL, comprehensive microbiology evaluations, cytology. You can send flow for CD4, CD8 ratios. And then at this point, if they're enrolled in our trial, I'll perform transbronchial biopsies, again, cryo versus transbronchial biopsies. Or depending on the case, I might get parenchymal biopsies, again, if it's sent maybe from our ILD multidisciplinary board where the patient may have ILD considerations. This might be something where I'll sample in that regard as well.
Mhm.
Um, Now, keep this in mind, though, keep this in mind, is that I am always using the information from the cytotechnologist. If there's a clear diagnosis that would allow us to forego parenchymal sampling, and I may not have to proceed with that, then I may not. If they end up telling me that this looks like it's malignant and we have it off of the lymph nodes, then I generally will not proceed with parenchymal sampling unless it would be one of those cases where it was um, would it be an ILD or something with that respect? But if it was for the sarcoid evaluation and it ended up being something different that they were telling me and I had enough tissue to make the diagnosis without having to put the patient through additional risk, then again, we're always assessing that and we would adjust our procedure accordingly. But again, I will tell you this: just looking at some of the data that we have from our comprehensive biopsy sampling for suspected sarcoidosis, you would be surprised how many times you make the diagnosis of sarcoidosis with granulomatous inflammation, not in the lymph nodes, but on the mucosa. And sometimes we make it on the parenchyma with only minimal parenchymal change seen on CT, with negative lymph nodes, negative mucosa, and a non-revealing BAL.
Mm-hmm. Yeah, that's where I struggle to understand the role of forceps in sarcoidosis. I mean, I've been routinely using a 25 gauge needle, and we get granulomas all the time.
Mm-hmm.
I mean, granulomas are microscopic structures, so I don't think the gauge of the needle should have any effect on seeing granulomas or not. And this goes with architecture. I think it's more important for lymphomas and subtyping them rather than in sarcoidosis. So I haven't really seen the need or had a case wherein I've had to jump to a forceps for sarcoid yet. But again, lots remains to be seen, and we look forward to more studies on this. So,
Absolutely, absolutely.
if I may clarify one thing, you are using the 1.2 millimeter Cordiax forceps by Boston Scientific, right?
Correct.
Okay. And can you please briefly describe your technique as to how you're doing this?
Absolutely. So for the mini forceps, I we are using the 1.2 Core DX currently. But the first method, there's a couple of different methods, and I will tell you that I don't use cautery to make an incision as was described previously with the larger forceps. With the mini forceps 1.2 millimeter Core DX, I find that you can get the forceps through the tract quite easily, and you don't need to make any incisions. But so when I was looking at this and describing this, I don't know if maybe I've coined these two techniques, but the first method, what I call, is the bronchoscopic view technique. Okay. So using the EBUS scope to estimate the trajectory of the forceps, which should generally follow the angle of the transbronchial needle, you can create a needle tract just by your usual EBUS TBNA sampling. However, once you have a location in mind, you have to keep the scope completely still. So you'll create a tract by passing the transbronchial needle through the wall into the lymph node, roughly 5 times, roughly more or less about 5 times. So you want to go completely through the wall into the lymph node each time. And then at this point, you can reacquire your bronchoscopic view after you take the needle out and visualize the tract site. So after you visualize that bronchoscopically, you then insert the mini forceps through the working channel and through the tract insertion site. So the forceps should pass through that tract without much resistance. So if you have resistance, pull the forceps back into the channel, reposition ever so slightly, and try again. After it passes through the wall, then you would then engage the EBUS scope to regain your ultrasound view, and you would visualize the instrument entirely under ultrasound. And then I will then place the end of the mini forceps at the proximal end of the target. I then open the forceps, advance it towards the distal edge of the target, again maintaining continuous ultrasound visualization, and then I close and then remove the sample. And then if you can continue to keep your bronchoscopic view, you can then hopefully take the forceps back after they process the sample and just go directly back in without much movement of the scope. But this technique, I think it can work. However, in my experience and looking at the results of the biopsy samples, I have a suspicion that if ever you're going to traverse the airway wall and be adjacent or off the edge of the target, then I feel it is with that bronchoscopic view technique. So what I generally do is the second technique, and what I call this is the ultrasound guided technique. So what I'll do is I'll load a transbronchial needle and adjust the sheath as per usual EBUS TBNA technique. I'll find my target and try to maintain a neutral position and to create the needle tract. So I do want to create a neutral position. I do want to be in a neutral position. So yes, at times you might lose partial ultrasound view when you're creating the tract. However, just keep in mind, if you flex, rotate, advance the scope, as soon as you remove that needle from the tract, I feel that the scope will slide slightly. Okay. So once you're in position, you maintain completely still and in a neutral position if possible. You pick a spot and memorize a conspicuous mark on the ultrasound image that you can remember and use that as your needle entry tract point. So you can even have someone hold the bronchoscope at the endotracheal tube or the LMA to keep it secured there. And then from there, you create the needle tract by inserting and completely removing the needle from the target and the airway wall. And as you create more insertions of the needle, as you pass through the tract, it should get easier to pass the needle. So after about five agitations with the needle to create your tract, you should have your assistant be ready with the mini forceps biopsy near your scope for when you're ready. Then you memorize that insertion point based off the ultrasound view. Hold everything completely still. You'll then remove the needle completely while still focusing on the ultrasound view. And with your peripheral vision, grab the mini forceps and insert it through the working channel and smoothly through the ultrasound point that you memorized. And so at times it may not pass, and you shouldn't feel much in the way of resistance. And if it doesn't pass, then you make very minor adjustments. So that may be where you slightly flex or extend, rotate slightly, or very slightly reposition the scope. But the key is memorizing the insertion tract on the ultrasound view and inserting the forceps with minimal resistance through the tract. So, and then in reality, I usually use a combination of both. Sometimes I'll use, I'll get a view and then I'll use the ultrasound view. So I'll probably end up using a combination of both. But a couple of technicalities I've noticed with our trainees is that if you're going to fail, the failure rate is higher if you don't create a good tract. If you create any torsion on the scope, flexion, extension, and that'll change your angle. If you try to insert the mini forceps and it doesn't pass, when repositioning, the mini forceps will be outside of the scope slightly. If that's the case, if you have it still outside of the scope, then it can drag or it can anchor. So when you're trying to make your adjustments, it really won't move you all that much. It does make it harder to find the track. And finally, the last thing that I noticed is that have the mini forceps, your assistant holding that close by for you, so that the time from removal of the transbronchial needle to placement of the mini forceps is minimized. So that really matters. Sometimes you'll see the bronchoscopist looking over, over their shoulder to try to grab the mini forceps. They'll take 2 minutes in between removal of the needle and placement of the mini forceps. They'll take their eye off the ultrasound insertion site. And those are all things that can lead to unsuccessfully getting or to not getting the forceps into the tract successfully.
So once you're in the lymph node, do you just take one bite or do you do a Pac-Man like maneuver?
Yeah, so I've been trying to discern which one is better. So with the initial spy bite forceps, I feel that it's easier to get into the tract, but I don't feel that the actual bites are as large. And so with this, I'll do a single bite. With the Core DX, I feel that it's a little tougher to get into the actual tract, but I feel that it has more of a cup that can acquire more tissue. So sometimes I'll do, like you're saying, either a double bite where you go proximal open, distal close, and then bring back to proximal open and then distal close again. But again, I don't know which one consistently would yield the most tissue.
Fantastic, Chris. This has been great. I think your views on a topic that have very minimal good data out there will be very well received by our listeners. And thank you for all your technical expertise. We're coming to the end of this talk, so I just want to ask you if you have any summary or closing points to make.
Perfect. So for summary and closing points, I would say the following is that for EBUS, we're getting to the point where I think that we're seeing improvements in the scopes, we're seeing improvements in the techniques, we're seeing improvements in the technology and instruments. And so moving forward, when we start seeing these conditions that can be challenging to diagnose, just know that we have other instruments that can augment our diagnostic yield. As we had mentioned earlier, there are studies where combining both modalities can increase our yield. And so for certain conditions, as we were talking, lymphoproliferative disorder, potentially benign isolated mediastinal lymphadenopathy, granulomatous inflammation, and even for those difficult to diagnose malignant disorders where they're asking for molecular analysis, next generation sequencing, just know that you do have another instrument that is available to you. It's certainly something that you can learn. It's something that can be done safely. And I think that it is something that if we use, we can potentially improve patients' outcomes by reducing the need for a second procedure and hopefully getting all the information we need in order to formulate a sound treatment plan for all of our patients.
Perfect. And I guess we both can agree that we need bigger, better studies before we recommend the use of the mini forceps for any indication.
Absolutely.
Perfect. Thank you so much for your time, Chris. This has been wonderful. And hope you have a good day. See you.
Okay, thank you.
With that, we conclude an exciting episode here on the AABIP podcast. I hope you guys enjoyed listening to it as much as I enjoyed hosting it. Do also check out our website, theIPpodcast.com, and please do provide us with feedback and suggestions on what topic and which expert you want to hear next. Until next time, take care.